Good morning, everyone. Welcome to Provincial Stroke Rounds. My name is Sue Burley. I'm the Regional Education Coordinator with the Northeastern Ontario Stroke Network. We're based at Health Sciences North in Sudbury. Today's presentation is titled Health Sciences North's EVT program, how it started and how it's going, presented by Dr. Ravinder-Jeet Singh, stroke neurologist and the medical director of our network. Our guest panel for the Q&A session includes Dr. Avi Deshmukh, stroke and interventional neurologist, Dr. Ruba Kawan, interventional neuroradiologist, Dr. Stefano Priola, neurosurgeon, and Susan Bursey, the regional director of our stroke network. For your information, there will not be any handouts for these rounds today. This webcast was recorded and archived and will be accessed through the link provided in the follow-up email we will send out later today. Please ensure that your microphone is on mute for the entire presentation. We will have an interactive component. It will be held during the last 15 minutes when we will have a question and answer period with our panel of experts. We hope to hear from as many people as possible. Please type your questions into the chat throughout the presentation and we will read them out during the Q&A. Please complete the evaluation at the end of this morning. You can scan the QR code to fill out the survey that you see on the screen now, and the link is also posted in the chat. Certificates of attendance were attached to the invite email, so please fill in your name and keep for future reference. And just go to the next slide, please. Here's our mitigating bias slide for you. And I'm now pleased to introduce our speaker for today. Dr. Ravinder-Jeet Singh is a stroke neurologist at Health Sciences North in Sudbury, and he's the medical director at the Northeastern Ontario Stroke Network. As well, he's an assistant professor at the Northern Ontario School of Medicine. Dr. Singh completed his medical school and neurology training in India. He did a one-year stroke fellowship in India before moving to Calgary, where he completed his two-year vascular neurology fellowship at the University of Calgary. He has a strong interest in studying the role of brain eloquence in stroke prognosis. He is also passionate about studying long-term outcomes after stroke, cerebral collateral imaging, and symptom imaging correlation in cerebral venous sinus thrombosis. Welcome, Dr. Singh.
Thank you, Sue, for the kind introduction. And on behalf of my team, I thank you all for joining today. So in next 45 minutes or so, I'll be presenting our and our region's journey from starting as a region with no EVT service to currently 24/7 service, and how we started and where we are currently. Here are my disclosures, nothing relevant to today's presentation. So the objective is to describe the EVT program at Health Sciences North from its launch to current state, supporting the 24-hour window for the treatment, identify the challenges experienced in the Northeast during implementation and growth of the EVT program, and finally talk about how our population looks like and discuss some of the procedural and process-related challenges at HSN patient outcomes. So prior to February of 2020, Northeast Ontario had no EVT service. We were actually the last and the 13th region to become an EVT site. We have a land size over 280,000 kilometer square, which is slightly over the size of UK and short of size of Italy. So it's a fairly large geography, and having no EVT site service was quite a challenge for our population. And these patients were transferred to centers in Southern Ontario, and we were very fortunate to have good collaboration with many of these sites, and these patients were treated there. But unfortunately, because of our geography and weather conditions, there were frequently long travel times, and also because of the longer distances, we had limited transport options, and it was almost exclusively a transfer by Orange. And so just to show you the flavor as to how the distance time map looks like. So prior to Sudbury being the EVT site, most of the Sudburyans, or almost everybody who was eligible for EVT, had to go to center in Southern Ontario, and it is almost 400 kilometers. And if you try to transfer these patients via ambulance, it takes almost 4 hours. Air transfer is shorter, but the challenge is the number of orange bases we have. So therefore, I would say in most cases, unless the orange asset was at our site, the distances, despite being shorter by aerial distance, the travel time was much longer. And just to show you, after becoming Sudbury as EVT site, of course, close to 1/3 of the population of the Northeast lives in Sudbury and neighboring areas. We have reduced that the gap or treatment delay. And also for other centers in our region, we have slashed the distance by almost half, and therefore cutting down the travel times. But more importantly, we have now opened a window for the land transfer, because now you can see many of these centers are now at a distance which is more manageable by the land transfer. And again, given how the population is distributed, we have a lot more patients who are a drip and ship model. So ideal scenario is we all want our patients to be a mothership patient where they have a shorter stroke onset to the arterial puncture time. But the reality is that a lot of our patients are actually drip and ship, therefore, which adds to this long delay. And you can see just watching that bar moving is also hard to see as to why it's taking so long. And so you can imagine how these distances and therefore the impact on the transfer time was impacting our patient outcome. And as you can see that this has been nicely shown by paper by Dr. Saver, published in JAMA, where they showed that with every drop, every increase in the treatment delay, that is an hour delay in reperfusion time, translates to approximately 10 to 15% drop in their odds of having good functional outcomes. So it's a very, very important and when determining how the EVT service should be organized. And so we had the evidence that the treatment works. We had the evidence that it's very time sensitive, and we knew that the region does not have EVT service. There was a lot of interest from the patient, and actually some of our physicians' family members who had good outcome after the treatment was also a big impetus in terms of promoting that we should develop the program here. And of course, there was also interest from the providers and policymakers, particularly locally. And the selection of the HSN being a regional site was, if not easy, but was relatively straightforward, given we have a lot of EVT, a lot of regional services, including cardiac, cancer, and vascular. And moreover, the biggest proportion of population in the north lives in Sudbury. And so this was a big task, and there was a lot of homework to be done. And this is just to show you a slide. I won't be going through it, but it's just to show that there are several steps when any site is planning to become an EVT site, and there's a lot of homework to be done. So some of the early work which we looked at was that how many patients were already transferred to Southern Ontario, and this is just a bit older data, but basically was our starting point. That over 9 months there were 16 transfers which were accepted, and only 2 were treated, mainly because by the time they arrived, either they recanalized or the stroke was completed. And therefore, you can see the EVT rate was quite small. And just to give you a sense, more recently, which we have started collecting all the transferred and treated patients, almost among 55 patients who were transferred, we treated close to 45 patients. So you can see how much impact it has, although we are planning to look at it in a more systematic way. And so the initial idea was to kind of form a program development working group, and that group then will engage different stakeholders and different collaborations, which I will describe. And so this was our initial plan. It looks quite impactful in terms of the steps which we have to take. And again, after getting a commitment from the radiology department, we then moved to the senior administration to approve that this is something which we should get into. And then we formed the EVT working group, and thereafter we engaged the different stakeholders, both local and regional, to then plan out the implementation of the EVT program. And so the first step after forming the EVT working group and engaging the senior administration and the other local stakeholders was to find what is our current state and what are the key action items for us to become an EVT site. So what are the steps or the key areas we have to work on? So we basically divided them into based on the model that patient comes to emerge, followed by imaging. What is the current treatment algorithm? What are we going to do in the angio suite? How the anesthesia support is going to look like, and how the post-procedure care is going to look like. So these, from the current state, we then identified these key areas, which included a lot of aspects of education, getting additional support from different departments, and having that initial exposure to the team, for which I think the key aspect was the collaboration. So we were fortunate to have a great mentorship by Dr. Krings at UHN, and also we had very close association with Kingston Health Sciences, who really helped us in the initial stages of the planning as well as subsequent implementation. And so this is kind of a key milestones. It was hard to put into the timeline, and therefore just created more of a key teams, which you can see. And just to walk you through, prior to 2019, it was mainly into planning phase and getting approval from the ministry. In 2019, the key theme was the lot of education for the team and establishing the referral process, repatriation process, and 2020 was the launch. And thereafter, we have strived to improve our service. And so in spring of 2019, we received the endorsement from Core Health, and we were approved for 12 cases. So that was our the biggest success in terms of ensuring that we go on to have a complete 24/7 AVT program. And we were the 11th hospital in the Ontario and first in the Northeast. And then we agreed on the activation model. So once we had the funding, we had all the stakeholders involved. We had to then agree as to what the activation should look like for patients who are presenting at our center and the regional patients. For the regional patient, for the most part, I would say it's pretty similar approach because telestroke is involved, critical is involved. So it's a fairly standardized process. The main task was to have a consensus as to how the local process is going to look like. Because for the TPA delivery, we have a combination of the neurologist and the intensivist. And prior to me joining in 2019, it was all the intensivist service group who was providing the TPA. And so I was the first stroke neurology, and thereafter my colleagues joined, and then we became a complete team and providing more and more coverage for TPA and of course, all the coverage for the EVT. And so currently the model which works is that there is often pre-notification by the EMS, and the ED then pages the stroke neurologist or intensivist depending upon the call coverage. If the intensivist is first on call, he or she pages the stroke neurologist and IR if LBO is detected, and stroke neurologist then involves the rest of the team. And we also have interventionalists if it is a go procedure, then the intensivist calls, interventionist calls the anesthesia and the angio team. And so after agreeing on the activation part, we then had to agree as to how it should look like, because we cannot go start the 24/7 service. I was the only stroke neurologist, and we had Dr. Priola, who was the only interventionalist. We had initial locum coverage by Dr. Jesse Klosterneck, who was actually the first interventionalist to do the procedure here in Sudbury. And so initially we planned for a phased model where we'll start with the phase one, starting with the limited hour business hour model, and therefore increase to phase two, which was extended business hour model, and thereafter going to phase three. But after talking to the critical, which maps only in two ways, either the business hour or a 24/7 service, we then merged the phase two and three into phase two. And thereafter, we performed the first mock code. That was in February 19, 2020, where one of our stroke floor nurses volunteered to be a model patient. She was picked up at home by an off-service ambulance. And thereafter, we ran the entire code stroke, including transfer to Angio's team and the mock EVT. The entire process was recorded and the code was debriefed and trying to understand if there was any improvement which needs to be done in this process. And interestingly, it was a very timely mock code because the day after we had our first case. So this is our first case, 57-year-old man who was one of our patients from the neighboring community and had left distal IC occlusion. And we did one pass, and you can see a large chunk of clot, and it was a TICI-3 reperfusion. Patient actually had a fantastic outcome and MRS of 0 at 3 months. And so this was actually a good start, and it was very encouraging for the team. And most importantly, the team, which was initially trained, had no prior experience with the neuro cases. So although it had a lot of mentorship and training at UHN. And we did debriefing after each case. For the first 6 cases, almost every case we debriefed, trying to understand if there was any process-related improvement we had to do. And so this was the initial team. You can see many of the team members here, and many of you might be familiar with some of the faces. So Dr. Sove, Dr. Klosternek, Dr. Priola, who was the first interventionalist, and our stroke nurses and the angio, as well as the emerge nurses. And Susan Bursey, you might have seen on many forums and platforms, and Dr. Pranam, she was the medical director back then prior to I took that role. And again, we had a great collaboration with our radiology department, and Tracy, who's the manager and was very instrumental in enabling a lot of the processes in the angio suite. And again, there was a celebration. Everybody was enjoying champagne, and so this was based on our first few cases. We recognized a lot of challenges in terms of delivering the care. The biggest hurdle which we found is that I have listed them here. It was the coordinating the team activation, because there was a lot of phone calls initially, and some of painfully, I remember that I was on phone for almost 30 to 40 minutes, just trying to call different people and making sure we had everybody coming in and being available. So subsequently, we have streamlined this, and now we are working on a fan-out paging system which can send out pages and text to everybody, or even calls. And the second part was the team mobilization, which is closely linked to team activation part. And the angio room preparedness was also slower because partly the angio room is shared by the peripheral IR and for the neuro IR. And a lot of time, the angio room was prepared for peripheral IR, which is what happened most of the time. And therefore, that has to be changed to the neuro IR. And this we have took a big step by Dr. Kivan took a lead role in this, and we are now preparing the rooms. Usually before the weekend, the room is prepared for EVT case. And also we try to keep most of the items in the room to reduce the delay. Anesthesia wait time was another aspect where we had to wait for the anesthesia to arrive, but now we got consensus and an agreement with the anesthesia that they don't have to be present before the procedure starts. And now also the team is very comfortable in terms of starting the procedure. Handover issues was another challenge, and I think it was the big one. Where from emerge nurses to the angio nurses to the ICU nurses. And again, we streamlined the roles and responsibilities, and there was a team learning curve, mainly because most of our staff was not trained in neuro procedures, so there was learning curve. And after a few cases, we saw big improvement in terms of the performance and the workflow. Device-related challenges was another thing which we learned the hard way, and we found that we had, which I'll be showing shortly, that we had a lot more carotid cases. We had a lot of patients with ICAD. We had to deploy sometime intracranial stent. We had to do angioplasty. So we had to get the right balloons and the right stents. So population-related challenge was another, because a lot of comorbidities, and it could partly be related to poorer access to the primary care in the region. A lot of patients do not have family physicians. Therefore, when they present with a stroke, that's when we recognize a lot of the comorbidities, and also the regional challenge in terms of the transfers, which was quite difficult in the beginning from the referring site. The process was not well oiled, and there also I will be showing that we took a lot of QI related approach. And so after this initial, there was an expansion of the team, and you can see the timelines as to who was the interventionalists at different time points. And now we have a full team. We have 3 interventionalists. Dr. Deshmukh is also a stroke neurologist. So 2 of us, we do 1 and 2 stroke call for EVT, and he does 1 and 3 EVT call. And Dr. Priola has been the key provider from the initial launch to till date. And then Dr. Kivan and Dr. Deshmukh joined last year. And after the team expansion, we wanted to expand the program in terms of adopting a bigger window to 0 to 24 hours, because we were limited in the 0 to 6 hours initially. There was a lot of training for the ACT-FAST, which was rolled out for the region. We involved the EMS and Orange in the discussion in terms of impact on them for these transfer-related discussions. We developed direct pathway from James Bay Coast to avoid secondary transfers, where we now are on a 3-way call. If there's a patient there, it's a direct transfer to HSN. We also developed a direct pathway from Parry Sound in the late window, which is a telestroke site. And in November of 2021, we became 24/7 service. And of course, we involved many stakeholders just to involve them in the impact discussion. This is our current team model. We work on a single plane machine. We have anesthesia for every case, and we try conscious sedation almost all the time, except a few cases where we had to intubate the patient. We have stroke neurologist, which is available throughout the procedure, and many times is actually with one of the interventionalists. We have 2 operator, 1 primary and 1 secondary operator from the initial start to date. We have 2 angiotechs, and the reason for 2 operators and angiotechs was mainly to have more team training. And we have 1 RN and 1 RT, which is case by case, and we do not have stroke or IR fellows. And so after agreeing on the process and timelines, it was important to ensure that there is a peri and post procedural care orders, which we developed. And also we developed the angio data collection form, which feeds into CAI-HI, but also it's a very key resource for our EVT database. And the post-procedure care at our center is every patient goes to ICU for 24 hours, followed by follow-up imaging and admission to stroke unit. For the regional patients, repatriation is initiated within 48 hours, and it's usually closer to the patient's home, whichever is the closest stroke unit. And we follow all our patients, treated patients in stroke prevention clinic at 90 days. This is just to show how our program evolved in terms of the activity. So the first fiscal year we only had February and March. So we did 2 cases and we were business hour model. Here also we were business hour model, and we did 13 cases. Halfway through into the 2022, 2021, we became 24/7, and you can see a big jump in the numbers now because we opened up not only the window to up to 24 hours, but also the treatment window up to 24 hours. So we became 24/7 service, and a region adopted a 24-hour window. And this year, this fiscal year, we are expecting close to 72 cases, and we are funded for 72. We have already done close to 32 cases so far. This is just to show the access to EVT, and this is the upper line shows how the region, how the province has increasing volume of the EVT and access to the EVT care, which is per 100 case of ischemic stroke. And here you see that the curve was pretty flat before we started rolling out the EVT. And even you can see there was a big jump when the planning was going on. And thereafter, the numbers have increased. And this year, we are hoping will surpass 5% access, which will be close to the province. And the procedure related summary here, you can see the breakdown of the number of cases, and you can see the program is definitely growing. And this is up to August. In September, we have done, I think, 3 more cases. So we are close to 32. This is how our different regional areas are represented in the treatment cohort. And of course, given the largest population lives in Sudbury and neighboring areas, we have the largest representation in the EVT cohort as well. And we have almost equal division of the procedure performed during and after business hours. Now, that's very relevant in terms of understanding treatment or the workflow. Because after hours, if the team comes in, and so everything has to be mobilized, and therefore it reflects in the workflow. The population, this came not as a surprise, but I would say this was a bit unexpected, as I will show in the next slide. Although the demographics were pretty standard compared to any other place or what was in the trial. We had a fair bit of vascular risk factors and a lot of smoking history in our patients. And even previous stroke history was quite 1 in 5, and a lot of cardiac comorbidities. So this was not a very healthy population, or at least reasonably healthy population. And a lot of these factors, all of these risk factors were identified when they presented to us. And in terms of the stroke characteristics, the NIH was 15, median, and aspects was 8. So it's fairly similar to the trial criteria. The location of occlusion, the most common was M1. And of course, we had patients with terminal ICA, as well as 4 patients who had posterior circulation stroke involving basilar artery. What is most interesting is the tandem ICA disease. So we have close to over half, 1/3 of the patients who have tandem disease. And when I say tandem disease, it's patients who have at least over 50% stenosis, and a lot of these patients were actually carotid occlusion. And so that was a challenge, adding delay in terms of the reperfusion, and also requiring additional extracranial procedure. As far as the procedural outcomes are concerned, we had TK2B3 reperfusion at around close to 80%. Which tells about how technically sound our interventionalists are. And the carotid intervention was done in about 13 patients, which is about 15%. But this constitutes about over 45% of the patients who have tandem disease. And in terms of the workflow, we were pretty good in terms of our door to CT time. So a median of 17 minutes. And you can see the door to puncture time was 108, which means the imaging to puncture time was close to 90 minutes. Now our target is to get it under 60, hopefully in the next year or so. And the reperfusion, there was a lot of delay, mainly because a lot of patients were regional transfer patients. So we were close to a 5.5 hour mark. And in terms of the patient outcomes, we had a mortality which was quite significant, which is close to 30%. And partly this is related to the population which we are treating, as I mentioned. And so what was the key learning for us? That our population had some of the unique features. We had a lot more tandem occlusions. We had ICAD. We had a total of 5 patients who required either intracranial angioplasty or stenting, acute intracranial stenting. We had much more smoking history, partly because the region has a lot of places to have leisure activity. And we had a lot more that medical risk factor burden, which might have contributed to our patients' outcome. And so these are the lessons learned so far, and it's just to highlight what were our key takeaways from while we were developing this program, and eventually we developed it to 24/7 service. The first was we defined the scope, and for us, the scope was beyond local. It was a regional scope, which created unique challenges. And the scale of the service, of course, we had a lot of patients with a wide variety of how they were entering into the system, including the walk-in patients coming directly to the ED, then bypass protocols. We had patients from the region with different imaging and telestroke capabilities. Then engaging all the stakeholders early in the planning process, although we tried to be as inclusive as possible, but we realized that there were sometimes some of the departments which wanted more early involvement and wanted to be more engaged. So I think it's important to identify and communicate early and regularly, and provide major updates in the protocols or pathway change to really assess for the possible impact on those departments, and provide feedbacks for any queries raised, which we did regularly. In terms of the patient flow and individual roles, that has to be defined early. And as I mentioned, some of the things which we learned the hard way, although we had initial consensus, but having that clearly articulated and assigning those roles was quite important. And that also included taking many roles onto you, to making sure that the communication is timely, so that the team is activated in a timely fashion. Having a written protocol for intra and post procedure care, which was quite similar to what everybody expects, and we had to come up with some unconventional solutions in terms of how we set up our angio suite, again, given how our infrastructure is, and also to set a clear expectation. And this also we learned the hard way, because some of the referring sites were a bit slower in terms of repatriation. So we had to engage the right people from those referring sites, and we had a lot of district support, or the district stroke coordinator support, who really helped us streamlining the repatriation process, and providing initial and ongoing education. And that was also important, and providing feedback was also important, to learn from the delays, and also to kind of celebrate patients who were transferred quickly. And I'll be showing one of the patient later on. And we established audit tools, database, and we reviewed cases and learned from them. And of course, celebrate success and encourage team, which was very important. And so once we became live with 24/7 model, now the key aspect was to ensure that we have QI process, and we had to improve what we had already achieved. And for this, a lot of QI approaches were adopted, and I'm just going through a few of them. We started debriefing every case. As I mentioned, the first 6 cases were debriefed. Even subsequently, we tried to debrief some cases if there was any workflow related issue. We developed angio data collection form, and this had a lot more data fields than the typical form has, and mainly because we wanted to capture if there was any QI or workflow related issues which we can identify. We established a database which prospectively now enters all the transferred and treated patients. And the transfer patient we started entering from this early this year. while the treated patients are from the inception of the EVT service. We have the weekly stroke rounds, which I moderate, and we discuss almost all the EVT cases, and also we discuss other cases which our regional hospitals are able to bring, and if they have any challenges in managing any of the patient, we help them through this rounds. We started the QI work group. We recently had our first meeting, and this QI work group now has identified some of the key themes which we will work in the next year or so to improve our workflow and system, oil the system. And so these are the couple of other things which we did and which I just spoke, which is setting up the room at the end of each shift so that it's ready for any after-hour case and also weekend case. EVD product package, which we started and which has probably, we think, has reduced our time by 15 to 20 minutes. And we have now decision support who's helping us with the micro case costing. And we also started a regional QI with initially establishing an audit tool from the referring site. So this is for all transferred patients. And we also have case reviews with the referral sites, and we have with the transport teams. We had quite a few case reviews with the Orange to understand where the delays were happening and how we could improve. And during this process, we learned we can call them directly, and there was a direct number. And if there is, if you really want to expedite the transfer, you can directly speak to the transport physician, who is then able to then give a realistic time frame as to how the delay is gonna happen, and therefore you can then determine if you can fall back into the land option. So that was very, very helpful, and we got great support from Orange. We started regional monthly meetings for the entire region. Now we meet once a month, and which we will probably do quarterly to really provide a feedback and learn from some of the transferred and treated cases as to how we can improve, and also to celebrate in cases where there was an excellent transport or the treatment outcome. And we had great collaboration, as in addition to Orange, with the EMS, which we got great support to implement in every part of the EVT service which we rolled out. And then we also have the regional stroke rounds, which I mentioned. And we also have presence in provincial committees, and we perform update with the core health regarding performance, as well as there is an annual attestation form which we send. So this is work in progress. This is a project we got grant, so the idea is to understand factors which is influencing our access, and how after becoming HSN as an EVT site, how that access has changed. So we are quite delighted that we'll be working on this project to really understand any gaps and QI issues. So just to show a couple of patients to represent some of the successes which our team has. This is a 36-year-old man who had left vertebral dissection. He's a teacher, very high functioning. He was working out in gym actually a few days prior to his stroke, and noticed that there was sudden pop in the neck. He had some neck pain. Didn't think much about it. Started going to Cairo after the onset of the neck pain. And then on the day of presentation, suddenly in the afternoon, developed severe dysarthria, right-sided weakness, and he was brought to HSN. There was initial delay as he was thinking that maybe there's something else going on. He was not expecting that at 36 and being healthy and regularly going to gym, that he is prone for a stroke. So he eventually presented to us at about 7-hour mark. And you can see on the imaging, there is the left vertebral artery dissection. There is a basilar occlusion. He has an NIH stroke scale of 13. He was quickly taken to the angio suite, and you can see here that the basilar occlusion, it was a single pass primary aspiration. We removed a large chunk of clot here, and this was the post-procedure MRI. And he was discharged home after 5 days with mild residual dizziness. And this is what we got from patient's wife. And she was pregnant. It was very emotional. And when I was initially discussing with the patient's wife, because patient was barely able to speak as to what this is and what the procedure entails and what potentially could happen if we are not able to successfully retrieve the clot. Um, and she was pregnant. She actually delivered, and I followed them up last week. And they have a baby girl. And this is the email from her when she was pregnant and after the procedure, and when they went home, that if it wasn't for all of them, my baby would not have a father. So that was a very, very encouraging for the team, that they're doing a good job. And a 3 months follow up, his MRS1 for just dizziness, but there was no residual deficit. He's going back to teaching. His NIH is 0. This is one of the regional patient which we had, and actually we treated yesterday, and I thought maybe it'll be worthwhile to share this patient to show how the workflow, how the EVT, Sudbury being in the EVT side, how that has impacted our regional patients. So 61-year-old man from Cape Escasing, healthy, high functioning at baseline, woke up with deficit about 7 hours from last known well. He has dense hemiplegia to the right and global aphasia. And inequality, major infarction. You can see a left M1 occlusion, and he has a decent collaterals on this side. From here to and if you see, and so this is what is happening now is from this side, it's coming to Health Sciences North. You can see even if you try with the ambulance, the transport time is almost half, and by air transfer it was much quicker. On arrival, there were some early ischemic changes. You can see aspects was about 6. He still has persistent left M1 occlusion. Collaterals are good. His NIH was 21. And for people who really like CT perfusion, and you can see it's a fairly large volume of mismatch. It was this is a DSA. You can see persistent left one occlusion. This was a single pass combined, and we removed a large piece of clot, and he had a TICI-3 reperfusion. So in terms of the system and workflow, we were called at 12:16 via protocol. We accepted the patient after discussion at 12:25. Patient arrives here via Orange at 14:59. We did the repeat CT within 11 minutes at 15:10. Arterial puncture was at 15:40, which was about 41 minutes from the door time. We achieved TICI-3 reperfusion at 16:04, which was within 25 minutes, and he was ICU at 16:20. So there was no immediate post-procedure movement, but we're hoping, I'm going to assess him today to see how he's doing. So from the acceptance to full reperfusion, it was 39 minutes. And this, all credit goes to the fantastic team, which we have a pleasure working with, or I have a pleasure working with. There was a great support, great leadership. And just to mention a few acknowledgements, it's a very small list, and particularly I would like to thank our intensivist service, who has been really instrumental in enabling this service and also helping us to reduce our burnout. And Dr. Krings and UHN for the mentorship, and NGO team, Health Sciences Center, which really helped us in terms of giving showing us the flavor as to how it looks like being service, and all the departments. And it's just a partial list. And of course, we are also thankful for our regional partners and provincial partners. And I thank you all, and I hope I am on time, and I'm happy to answer any question.
Thank you, Dr. Singh. Excellent. Right on time, which is double excellent for me, as you know. We are now open to some questions. I'll ask the panel if they could put on their cameras for us and be ready. If you could advance to the next slide, the evaluation link can go up or back to the first one, whichever, and people could also be working on the evaluation. I'll start the first question, Dr. Singh, and then I'll hand it over to you. So I was wondering if you could elaborate on how you improved your patient transfer times.
I think that's we are still working on. Some of the early work which we did for our regional patients is to ensure that we have the right pathway uh, and understanding in terms of how the referral should look like. We had a lot of case reviews with our referring site to ensure that we set up the clear expectation and also learn from some of the transferred and treated patients, which we are now doing on ongoing basis on the monthly meetings. I think the important piece was the collaboration with Orange. So in addition to reviewing many of the cases who were transferred and identifying some of the issues with the transfer process, we learned different ways how we can expedite that transfer process. And also at what point we can trigger an EMS switch from Orange default, which is default for many of our sites given the distances. And now we have actually an agreement, data sharing agreement, which is in process with the Orange to understand all the transfers and understand the secular trends, the temporal trends over time. So we are starting from before we became the site and to becoming a 24/7 site. So this is something which is work in progress. And hopefully within next 1 year or so, we will have more data, and I would be happy to maybe have another provincial stroke rounds to share some of the QI related work and how that is impacting our EVT delivery service.
Thank you. We do have a question in the chat. If you could comment, or someone on the team can comment on the mortality issue.
Yeah, I'm happy to address, and I welcome all the panelists if they have any other thoughts. So the two key things which we identified is one was the burden of atherosclerotic disease, both intra and extracranially. We had actually 3 of the patients where we had to do redo procedure because they had early reocclusion related to intracranial athero. We had 5 patients who required some form of stenting or balloon angioplasty intracranially, and I would say that most of the patients in the poor subgroup were actually these patients. We also had 13 patients who required acute carotid procedure. And in one of them, the stent actually reoccluded and the patient had reinfarction. We also had a few patients which we more recently treated where they had borderline aspects. So there was before the transfer happened, there was some amount of or significant amount of brain damage, and for obvious reason these patients tends to do poorly. So partly this is related to bigger representation of the drip and ship patients, which tends to have worse outcome because these are even more remote communities which have even poorer access to the primary care. And the significant amount of large artery athero, both intra and extracranially. And also the cardiac comorbidity is quite high. We had a few patients who had ejection fraction of 20% or 25%, and one was close to 18%. Which was never recognized in the past. So I think it's the patient population which has the big factor to play. And partly this could be also related to the workflow because we are still about 90 minutes from the imaging to for the reperfusion. So some of this is related to related to the procedural challenges which we had, and also the team learning, which has substantially improved now.
Thank you. We have another question about the QI work in terms of what we've done already or plan to do in order to capture patient experience. Maybe Susan, you could share some of thoughts on that.
Hi, sure. We have shared patient stories throughout our journey at a variety of different forums, our stroke steering committee, staff huddles, at the beginning of education sessions for the angio team and other groups. And when we definitely get thank you notes and comments from patients through the patient representative, which we make sure we distribute to everyone who's been involved for that comments and feedback as well. But we're looking at ways to try to incorporate or try to obtain that patient experience in other ways in more real time. So we've been recently talking about how can we get a patient perhaps to join those monthly meetings that Dr. Singh spoke of in our new QI working group. How can we incorporate a representative from patients on that? We've just recently started talking about at the 90-day follow-up. Can we have a short survey? Can we incorporate a patient-reported outcome measure or something at that point? So we're definitely looking at what we can do, but this is new ground, so we would appreciate advice from other established DVT centers. If you're doing this effectively, we'd certainly like to hear about that.
Very good, thank you.
And I think I have just one comment to make, and our interventionist can actually might be able to answer this better, which I find was quite challenging. And after having worked at centers which has biplane machine, and working on a single plane machine was not a fun. And I would say some of the and which I should now add, the impact on the reperfusion times could be related to this working on single plane machine. And a lot of times you have to take projection, and it's a very painful to go from AP to lateral. So I will all the interventionalists are trained at centers which have biplane machines. So I'm not sure if they can provide some insight into what their experience was. It was quite a different experience for me, for sure.
I would agree with Dr. Singh. We all three of us were trained down south, and it's like driving on 407 highway and suddenly merging into a mud road of Sudbury, where you're using a single plane all of a sudden. It increases your procedural time. It increases contrast use. So what I saw after coming here, and it took me a little while to understand this, that we have quite a delay before patient arrives here. So already there is more ischemia, and with more contrast, we were seeing more contrast stagnation in post UVT CT scans, and we were getting calls, oh, maybe there is hemorrhage, where most of the times it's an extra contrast. It was a bit of a learning curve going through it, but I think few things which work really well for us is all three of us use same material, same methods, so there are less and less variation, and team is prepared. So that kind of helps us to focus on some other aspects which are not most suitable for us. Having an anesthesia support also is very, very vital, particularly when you are using single plane. Any patient movement really affects the quality of image, and further increases the procedure time. So having an anesthesia support is really, really vital. It was not available to us in Hamilton and wasn't a major issue in the past. I think we get a good quality CTA in all our peripheral sites, and we do a repeat CTA every time here, but we do much more analysis of CTA now, because we want to make sure what to expect on a single plane. When you have two planes, it's like two more extra eyes. So when you have only single plane, we study CTA much more, and try to look at what to expect, where is the occlusion, what is the best projection which will work. And these small things, we are working, these small things really help, but we are hopeful we will get a biplane in next year or so, and maybe we can have a faster, better procedure and probably a better outcome as well.
Very good. Thank you.
Dr. Priola or Dr. Kivan, any other thoughts? Because both of you also were quite well trained on the biplane.
Yeah, I totally agree with Dr. Deshmukh. It's a quite challenging start to move from biplane to single plane, especially with the population. What we see more tandem disease, people have more vascular tortuosity. So when your system start to herniate into the aortic arch, you have like to keep moving the machine from lateral to frontal projection. That's delay procedural time. And the first case from intracranial atherosclerosis, even we didn't notice that inside the procedure with the quality of the images, but then it's like later we have to get more attention. But I think the most useful thing also for the training of the team from the technologist nurses on such kinds of EVT when the patient come in a rush, especially after our procedure. And we have a big team from technologists and nurses that rotate, as you mentioned, between the peripheral IR. And we are different from other centers that our team also rotate in the cardiac lab. So that make also a challenge for the team to catch up with all these steps. And especially with the neuro work is completely different from the cardiac and IR work. So it's quite a bit of movement and steps for teaching of the team for the neuro IR work. So doing an elective procedure on a daily basis, such as carotid stents or embolization procedure, which we did since last year around 33 cases, was very helpful with two operators model that we have a time to stop, teach them. So that will be more comfortable environment than only for them to see this for the first time in an EVT patient.
Very good. Thank you, Dr. Kwan. There was another question in the chat. Dr. Singh, I'm not sure if you had covered this, but someone was asking if you could share how the team improved handover.
Right, thank you. No, that was, I think, a very important step, which we paid less attention initially. So what now is happening compared to earlier is that the emergency nurse stays there, and usually either myself or one of our stroke neurologists, along with the ED nurse, then provide a quick handover to the entire team. So we ensure that that happens in every patient. Some of the patient earlier, once the patient gets transferred to the angio table, the emergent ED nurse used to leave, and but there was no clear understanding that she has to provide the handover, which was happening on an inconsistent basis. Now we have streamlined that, and every in addition to the physician providing handover, it's now the nurse which provides the handover. The second is from the angio. Now, instead of the ICU nurse coming down and dropping the bed, now the angio nurse accompanies the patient to the ICU, so that every time the handover is provided there. So it's basically to ensure that from ED to angio and from angio to ICU, the nurses are providing their handover in addition to the physician handover. So.
Very good, thanks. Just about out of time. I wondered if Dr. Priola was on at all. I don't think he was able to join in this morning. So that's all the questions we have in the chat today. I want to remind people to fill out the evaluation. There's QR codes on the screen, or the link is in the chat. Thank you very much to Dr. Singh and to our panel for our Q&A. Very interesting. I think everybody learns from our learnings, and it was really helpful that you presented today, and we show that things are really moving and shaking in the Northeast. So thank you for being here today. To remind everyone, our next provincial rounds will be hosted by Toronto West Stroke Network, be held on Wednesday, November 2nd. And Dr. Joanna Shapsma will present treatment decisions in unruptured intracranial aneurysms, art or science. Thanks, everyone, and have a great day.
Thank you, everyone, for joining today. Thanks.
Thank you.
Thank you.
Yeah.